Hi, buddy, Dr. Daniel. Today I'm talking about, do prescription drugs work better than over-the-counter drugs? Well, migraine is a prevalent, common problem. It's found in 12% of the world population. For women, migraine is their most common medical problem of all problems they have, present in 25% of women. Men have migraine 6% of the time. Migraine can be a high-level disabling condition. And the next problem with once you've got migraine is what to do about it. Either ignore it and just take over-the-counter medicines and suffer it, miss work and school and things like that, or be more aggressive as a treatment program. See a doctor or even a headache specialist about it. Get on acute therapy medication, prescription drug, or if you're having a lot of headaches, get on a preventive drug. And those are the choices we all make in our lives. So the question is, do prescription drugs work better than over-the-counter drugs? And I would say yes. The answer is yes. Over-the-counter drugs are mainly painkillers, and some of them, if they have caffeine in it, are mild, weak vasoconstrictors. They only work at the pain part of the migraine process. But if you take a triptan currently still have been since about 1991 when the first one came out, the best drug for acute therapy for migraine. They can block the release of neurochemicals that cause the migraine. They can also block the other features of migraine, such as nausea. 80% of the time, persons who have migraine can get rid of the nausea part of the headache. They can get rid of sensitivity to light and sound. Over-the-counter medications are cheap. At Walmart, you can get 6 of the 200 milligrams Motrin or ibuprofen for $6. Whereas if you get 9 tablets of sumatriptan, 100 milligrams, that's $15. But for that, you have to see a doctor to get the prescription to get it going. So you usually have to have insurance. Else pay the fee for the first neurologic visit. Over-the-counters did not enter into the migraine process to any specific thing to block any part of that. They're just nociceptive blockers, which means they're pain blockers. The other problem is if you take too much of over-the-counter medications, they can increase the acid in your stomach and aggravate gastric reflux or even cause gastritis. But if you take one of the triptans at onset, 7 triptans present, they're all generic, relatively cheap, you can get a headache-free experience for 70-80% of persons with migraine within 2 hours. And you don't have anything like a 2-hour headache-free experience with over-the-counter medications. So triptans actually enter into the migraine process and block the release of the neurochemicals. That's how they work. So what is this migraine cycle I'm talking about? That's a 4-stage cycle in the brain that the migraine goes through a sort of pathophysiological reaction that happens in the brain in response to migraine. So the first thing that happens is there's trigeminal activation and cerebral arterial dilatation, stage 1. Then in about 20 to 40 minutes, the neurochemicals come out. By stage 3, which is about 2 hours into a migraine, the arteries and the nerves of the brain, the trigeminal nerve of the brain, are inflamed and causing pain or nociceptive activity. And by stage 4, they're affecting the thalamus, which is the pain center of the brain, deep inside the brain, and that causes severe migraine at that point in time. So really no other acute therapy migraine drug can do this, and triptans have been king of the hill, and they still are. I'm talking in a period of time of March of 2021, they're still the best drugs. Well, what about the new 2020 drugs that came out last year is what I'm calling them, and those drugs are Nurtec and Revli, both of which block the CGR receptor, while the other drug that's come out is Rayval, and that works on one of the 5-HTE terminals in the brain that causes a decrease in migraine reaction. But all 3 of these drugs are name brand. They're more expensive than the triptans are. They generally do not work as well as triptans are. I've already said that something like 70 to 80% of persons with migraine can get headache relief with a triptan if they take it at the onset of the headache. So something like 20 to 30% of persons with migraine could try one of these new 2020 drugs, see if they work. And also, since triptans are contraindicated for persons who have cardiovascular risk factors, like somebody who's had a myocardial infarction or who has out of control hypertension really shouldn't take a triptan. Well, they could try some of these new drugs and see if they have a better result from it. Now, Rayval, in my opinion, has a direct problem that's going to limit the use of the drug, because the FDA has said you have to wait 8 hours after you take the drug before you're able to drive a car, because it makes you drowsy. So just imagine a busy secretary or office worker at 4 o'clock in the afternoon, they take their Rayval, they can't drive home till midnight. Not a very effective situation, I think, for most people with migraine. So we'll see what happens to that drug when it's used more. Okay, next I want to talk about what do we mean by the over-the-counter drugs. So there's a class of drugs that are called caffeine, aspirin drugs. And basically they have caffeine in there, which is a weak vasoconstrictor because the migraine process causes vasodilatation, cerebral arteries. And also caffeine helps with absorption of aspirin. And so those drugs are Excedrin, Mivactin, and BC powder. The next group of drugs are called NSAIDs, or non-steroidal inflammatory drugs. There's a long list of these drugs. So the main one the public knows about are naproxen, ibuprofen, which is Motrin, Aleve, which is naproxen, and Advil. So those drugs are drugs that have painkiller relief. At higher doses, they have some anti-inflammatory reaction. They have nothing specific that works in the migraine process other than provide nociceptive help, which means painkiller help. And then the other drug is called Tylenol in the United States, or acetaminophen generic. In England, it's called paracetamol. In Europe, that's what it's called there. The problem with these drugs is that if you take too much of them, they can give you gastric reflux or problems like that I've already mentioned. Also, if you take too many over-the-counter drugs like this, you can get medication overuse headaches. So the International Classification of Headache Disorders has comments they make on the definition of how much of painkillers or a drug like that, even triptans, that you could take to cause medication overuse headache. So they say that if you take an over-the-counter drug like Tylenol or Advil, 1 pill 15 days a month, you can get medication overuse headache from that. If you take a triptan 10 days a month, you can get medication overuse headache. Or if you took a barbiturate drug like Provoke or something like that, or an opiate narcotic like tramadol or hydrocodone, 10 days a month, you can get medication overuse headache. But I would say no patient with migraine should ever be given butalbital or opiate narcotics, because there's an outbreak of deaths from opiate narcotics and addiction in America, which everyone is working on. And also butalbital type drugs have been banned in every country in the world because they cause medication overuse headache, except Canada and the United States. And we're unable to get that banned in America as of this date. Now, the American Headache Society has said that the number one drug that aggravates and causes medication overuse headache in migraine patients is caffeine, which is ubiquitous. And the Mayo Clinic has given a limit there for general health. You could take up to 400 milligrams of caffeine a day, and that's in folks who are healthy but don't have the migraine gene. But taking just 2 or 3 cups of regular coffee a day could be like 300 or 400 milligrams of caffeine a day. And on top of that, a patient may take Tylenol or Advil or an opiate narcotic. And that's how they get into this medication overuse headache race to the finish problem. So in general, headache doctors have said to patients they should limit all acute therapy drugs for treatment of migraine to no more than 2 days a week. And that implies the same number for NSAIDs, Advil, Tylenol, drugs like that. Any of the caffeine drugs for triptan as well, 2 days a week. Because if you're having 3 or 4 migraines a month and you start taking too much headache medicine, what'll happen is these chemicals start accumulating in the brain. Once you give them another day of treatment with Advil or something like that, that'll drive your brain to produce more chemicals to keep the fire going. It's just like someone putting lighter fluid on a charcoal fire, and it keeps the fire going, using the fire going for a charcoal burner or something like the migraine burning in your head. So you should limit drugs to only 2 days a week. Well, what could you take? What acute therapy drugs are available if you do get into medication-induced headaches? The list of drugs there are dopamine agonist, and those drugs are prochlorperamine or compazine, or chlorpromazine, which is thorazine. These are drugs in the past that have an indication by the FDA for treating psychiatric problems such as schizophrenia and bipolar disorder. But they're used what's called off-label, which means they're used for a separate purpose than the one for which they were brought out by the FDA. So these drugs do work because they affect dopamine, and dopamine being high is good for migraine because it helps persons with nausea, headache, and sedation a little bit so you can go to sleep. So those drugs are helpful. Dopamine antagonists. Then there are a group of prokinetic drugs here. This is Reglan, which is metoclopramide, and promethazine, which is Phenergan. Those drugs are used traditionally for treating nausea, but they also have a anti-migraine effect too, which is helpful. And then you could take atypical antipsychotics. The two big group here is olanzapine, which is Zyprexa, and quetiapine, which is Seroquel. So again, these drugs are used off-label for migraine treatment. It is said that the most beneficial oral drug here is olanzapine, followed by chlorpromazine. And sometimes persons who have a lot of restrictions for drugs they can't take, I'll use one of these drugs as acute therapy drugs as a go-to drug for that individual patient, and they generally work pretty well. You could also take an NSAID, which is called ketorolac. It's 60 milligrams intramuscularly. It's given every 6 hours. That's used all over America in the emergency room as a shot in the arm or the rear for patients to come in with severe migraine. You can take a beta blocker eye drop, and this is really a neat trick. I've used this for some period of time. I really like it. It's called Timolol, which is a Timoptic eye drop, and it's a beta blocker. The dose there is 0.5% solution. You can take 1 or 2 drops in each eye every 2 to 4 hours. So beta blockers are good drugs for prevention of migraine, and Inderal, the generic of which is propranolol, was the first drug the FDA listed of all drugs. So it was a preventive drug for migraine, and that came out in 1974. So it's a preventive drug for migraine, about 30% prevention of migraine. But it doesn't work acutely. If you take an Inderal today for migraine, it will not do anything for that. But this beta blocker eye drop is absorbed right into the trigeminal nerve fibers through the eye. That works really pretty well. And you don't get rebound from that drug at all. What's the difference between chronic migraine and medication overuse headache? Well, chronic migraine is defined by the International Classification of Headache as having 15 headache days a month, 8 of which have migraine features. And when we talk about migraine features, we're talking about severe, between moderate to severe headaches that are throbbing, usually one-sided, associated with nausea or vomiting, and sensitivity to light and sound. Medication overuse headache is a sort of chronic migraine situation that is produced by overtreatment. And the patient should tell the doctor their history taking a story of taking a lot of medications. And commonly these folks would be someone who's drinking 3 or 4 cups of coffee a day. They take Advil or Tylenol a lot, and then on top of that they take a triptan. I saw any number of patients taking a triptan every day for like 3 months or so. And the doctor had given it to them for migraine, but didn't give the instruction that you're only supposed to limit it to 2 days a week. And they got a medication overuse headache from taking a triptan drug, which is unfortunate. So medication overuse headache has the following features. They have daily or very frequent headaches, which come with sensitivity to light and sound and nausea and irritability. And the syndrome causes serotonin, which is a calming brain neurochemical, levels to drop. So the patient has increased level of anxiety, depression, poor concentration, panic attacks, and insomnia, which are also the core symptoms of medication overuse headache. I would commonly see in office patients who are taking like Lexapro to raise serotonin for anxiety or depression, but have medication overuse headache, and I would tell them, this drug, Lexapro, is not working, and it's not your fault, but it's not working because serotonin levels are dropping because you're overtreating with this syndrome. If we detox you, get you off the painkillers you're taking, your psychiatry situation and symptoms will improve, which is great. Okay, next I want to talk about when should you see a headache specialist in this situation. Well, when headache is more severe and medical treatments aren't working, if your diagnosis is uncertain, when headache is disturbing your life, your work, your friends, relationships, it's disturbing your sleep, well, it's time to see a headache doctor by then. Headache specialists have their own personal interest in headache. They like to read headache journals. They like to go to headache meetings. A high number of these folks, I think it's over 60% of them, have migraine anyway. And during their training as neurologists, they may take a headache fellowship program. And because most headache patients the doctor sees are generally healthy folks with a normal neurologic exam and normal testing, the doctor gets an accelerated increased ability to take a history because they see the same kind of medical problems over and over, which is very helpful in medicine. And the doctor may hear the patient used to have episodic headaches, I don't know, 2 or 3 months ago, like maybe 2 or 3 migraines a month, and all of a sudden, then they start developing these daily headaches, which are severe one-sided, nausea, and all that bit. And that's when they started over-treating, and that's the development of medication of his headache. Now, for that patient, the doctor needs to educate that over-treatment with headache medicines will give you a headache, and needs to instruct the patient to stop cold turkey the medicine, get off of them, or to slowly taper off for a period of time. Particularly if there's barbiturate drugs, sometimes that's tapering because that can lead to seizures and withdrawal symptoms. Opioid narcotics do the same thing. NSAID is pretty easy, just stop that, or triptans, you can stop that suddenly. And then the doctor may want to use a week or two of prednisone, which helps inflammation in the brain, and also to give some kind of acute therapy drug like DHE, dihydroergotamine is a shot or a nasal spray, or the timolol eye drop, as I discussed earlier. And they also probably would offer the patient to get on one of the new CGRP preventive drugs, Aimovig or something like that. All right, what are the concerning symptoms or red flags that should provoke a patient to see a doctor with headache or go to a clinic? And I'm going to just read this because it's a long list I've got. So if the patient has complicated headaches with unusual symptoms, if you feel weak or numb on one side of the body, you change the level of consciousness, trouble walking, change in memory, vision, or ability to talk, having a migraine longer than 72 hours, because that's how long migraine lasts according to the International Classification for Headache. Past that is really not a migraine, it's something else, either medication or his headache or something more severe. Persons who have complicated medical or psychiatric problems, like people with fibromyalgia, asthma, epilepsy, insomnia, anxiety, depression, or panic disorder. Persons who have a headache more than 2 days a week. Headaches that make you feel like you're going to miss social events, school, or work, or just doing that. Headaches that affect relationships with your family, friends, or co-workers. If you have a thunderclap headache, this is described as the worst headache in the world. A sudden severe headache, onset to peak within a minute or so. Those folks should really go to the ER and be scanned, CT or MRI scan, make sure they don't have some kind of a bleed in the brain like for an aneurysm. Positional headaches that come and change intensity with association with moving positions like standing up or lying down. New onset headache in patients who are over 50 years old. That's an International Classification for Headache diagnosis, but these people may have other medical conditions like cancer or some kind of blood clotting problem. Percentage of those patients have a hypertensive headache problem in the brain that causes that. If the patient has a documented change in headache occurrence, such as an increase in the frequency or change in headache characteristics, I've always had migraine, but now I'm having these kinds of headaches, they'll say. Constant headaches, which are always on the same spot in the head. Migraine with our patients who have a long or quick onset RF symptoms. So the International Classification for Headache says the migraine RF symptoms should only last 60 minutes. And usually they last 10, 15, 20 minutes or something like that. So these could be a visual aura, seeing a bright light, zigzagging lines, or fluttering images in the eye. It could be numbness on one side of the body that sweeps up into the face, or it could be short-term trouble talking, which is called dysphagia or aphasia, where you can't write or talk or progress, make language well. Any of those symptoms, if they're longer than 60 minutes, they really should be checked out and probably be scanned. Again, if the patient has a headache that never goes away, headache plus systemic symptoms, this would really bother me, such as fever, chills, weight loss, or night sweats. Wow. New headache patient, anybody with cancer, you're always worried about a metastatic lung lesion from cancer in the lung going to the brain or something like that. Headache that keeps getting worse over 24 hours. Any headache after a head injury, you're always worried about blood in the head there. Headaches that come with visual blackouts, pain while chewing, body arthritis, or weight loss. So that's temporal iritis. That'd be a concerning thing. Okay, what about taking preventive medication? You could call that daily medicine or prophylactic treatment. And it means the doctor intends his patient to take a pill every day, not one every other day or something like that. And generally most people need kind of a understanding that they're going to start this drug and they need to take it probably 6 to 8 weeks as a trial to see if it works. If not, talk to the doctor, come back to the office or something, we'll change it to something else. A lot of folks just want to take it 1 or 2 weeks. If it doesn't work, they'll stop. But that's really not long enough. So I stress that when you start a new drug like that. So preventive therapy could be recommended for someone who has 3 or 4 migraines a month. That's danger level. They have chronic migraine. The patients who've had medication overuse headache. Patients who prefer this type of treatment. Patients who've had significant pain that hampers their life. Patients who are taking a lot of over-the-counter narcotic, opiate, or barbiturate pain drugs, like I said earlier, who don't get enough relief from acute therapy medication they're taking. A lot of times you get on one of the CGRP drugs, their migraines aren't as bad, and previous drugs like triptans work better. Any person that's having a side effect from drugs used for acute therapy. So preventive treatment not be an option for patients who can control their headaches within the stage. Somebody, the easy migraine patient who takes like 2 aspirin, lies down for a nap, headache's gone, they go to sleep. Well, sleep seems to reset the brain and makes migraine better. But the deal is most of us are not able to do that. If we're working on the job all day long, we can't go take a nap for like 20 minutes. We're working. If patients who have other health problems that don't allow you to take preventive drugs, the patient may already be taking drugs that would not mix well with preventive drug. You have to check all that out. Contraindication medicines. But some people just don't want to take medication. Some people can get relief from their exercise situation, from their headache problem by exercising a lot, getting stress management or doing biofeedback, and God bless them, they can do it. Some people would prefer a medical device called Cefaly, C-E-F-A-L-Y, which is an FDA-approved treatment for migraine prevention. It's a little device you put on your head and gives a little shock to the trigeminal nerve. That's used once a day for 20 minutes. Also, patients who are pregnant are always worrisome patients. But I tell them migraine usually improves in the 2nd or 3rd trimester of pregnancy, only return later. Usually have the baby's delivered for most folks. A lot of OB doctors allow their migraine patients to use Tylenol. Headache doctors will allow the patients to take CGRP drugs or triptans. Now it's okay. So here we are at the final step here. What are you going to do? You're going to take an over-the-counter drug or a prescription. And here I'm going to just put a lot of my own opinion into this. I got to admit, I've been a neurologist and headache specialist for over 40 years. And I would answer to that question, see a doctor and start prescription medicine for migraine, at least an acute therapy drug. If you're having headaches 3 or 4 times a month, you might consider a preventive drug, one of the CGRP preventive drugs. Now, a lot of people with very mild migraine, they take 2 aspirin and take a nap group. They're really not searching the internet and reading web articles on the treatment of migraine because they don't need to. They don't bother them that much. Their migraines are not severe, and they're living with what they're calling their hungry headaches, their menstrual headaches, their sinus headaches, all of which are names for migraine. It's just not bugging them and bothering them very well. And they don't need to see a doctor until they start over-treating and they get into medication, overuse headaches sometime in their lives. But persons who are having migraine attacks more than 3 or 4 days per month are they're walking on the edge of medication overuse headache. And sometimes a sit-down visit with a regular doctor or a headache doctor might discover that risk. And also, I usually ask the patient, what's the usual period of time between the onset of your migraine and the peak? What is that? Is it a slow period of time, like an hour, slowly build up? Well, if it is, maybe an over-the-counter drug like Excedrin or Tylenol would work then, because they have time to be absorbed and get to the brain. Or is it a short period of time, like 10 minutes? Well, over-the-counters just don't work that quickly. They're not going to do much there. That person probably should be on a preventive triptan, one of the acute-acting triptans, like 6 milligrams, sumatriptan subcutaneous injection, or else zomatriptan nasal spray 5 milligrams, because those work in 10 minutes. But playing the triptan game, one wants to get the medicine in the patient's brain before these neurochemicals are released, because once they're released, they say triptans work any stage during a migraine, but they're not going to give you a headache-free period in 2 hours. You want to treat early here. And many people get it locked in their heads. They just don't want to take a daily preventive drug. And I understand that, particularly with the older drugs they may have tried in the past, like amitriptyline, topiramate, Depakote, or propranolol. Those drugs only worked about 30% effective, but they worked, but they were just not very well. However, the new CGRP preventive drugs are amazing. They're something else. They do require a subcutaneous injection, usually in your arm or in the anterior thigh. But I tell patients, well, consider diabetics. They're taking subcutaneous injections of insulin 4 times a day unless they're on an insulin pump. And when I talk to patients like that, it always reminds me of talking to adolescents and young teenagers who will tell you, I can't swallow a pill. And I'm thinking, looking at the mother and wondering, what's going on at home with that child? So the new CGRP preventive drugs have rare, mild side effects, but they work so well, it's amazing. So what's been said about them drug is that 50% of patients with migraine have 50% reduction of headache. Well, it's already better than the older drugs, like amitriptyline. Another 25% get 75% migraine reduction, and another 25% get complete 100% migraine reduction. Wow, I've never seen a drug do that. I've seen many patients in this no migraine attack group, and recall that these people I'd worked with, some of them for years before, always trying different drugs and try to help them. So the drugs work well, and you should consider them. All right, the question of cost of CGRP drugs prevents really a problem because it helps to have insurance. They're more expensive, and many insurances really require the patient to fail previous preventive drug, like 1 or 2 months and taking propranolol or Depakote or something. You fail that with high headache numbers, then you could try it. And although the pharmaceutical creators of the new drugs like Eli Lilly, Teva, and Amgen and other drug companies have aggressively marketed CGRP drugs, and they even gave the drugs away at the beginning to try to get people to try them, the growth for these drugs and sales has been poor. Only Aimovig and Emgality are used by at least 10% of migraine patients. Wow. And that's a sad treatment experience from my point of view, considering how prevalent and disabling a migraine can be. I've had the person has no medical insurance but submits their financial data to a pharmaceutical company. They may be able to get the medicine for free. The way the pharmaceutical agent will do is they'll process that and look it all over. And they want somebody who's working with a doctor because they're going to probably send the medicine to the doctor's office, and they'd rather have a headache doctor to do that. You'd be more successful with that. So those are my thoughts on this condition of using over-the-counter drugs or taking real doctor medications for headache. I hope you enjoyed it. Thank you very much for listening, and I'll see you again on the next talk. Please click on like down there, please. Thanks also. Bye.